She's there in the attendees, but not in the panelists, no?
Can you, Ria, can you put her into the panelist from the attendees? Ria?
Hello. Hi, sir. Hello.
Ria, can you put Dr. Leenatha to the panelist group?
Okay. Lina Jana?
Yeah.
Okay.
Perfect. We can. Hello, madam. Good evening.
Good evening. Sorry about that.
Hi. Good evening, ma'am.
Good evening.
Hi, Linda. Good
Hi,
evening.
ma'am. How are you? You're still in the airport?
In the traffic, reaching home.
Okay. Good. Hi, Shalmy.
Hi, how are you?
I'm good. I'm good.
So I think attendees have started joining and we are on recording mode. So we can just start, Deepa.
Do you want to wait for some time? I think we still need some more. We have some numbers.
We have.
Not many yet.
But we are getting, they will join.
Okay, sir. Good to go. We are live now.
Hari, you can start.
Yes. So good evening, everyone. And today, as we are showcasing one more program of public awareness. Last time it was we talked about the growth and puberty problems in children. Today we are going to talk on hypothyroidism. It will include talk both on congenital hypothyroidism, that is which is present since birth or detected soon after birth, and one is juvenile hypothyroidism, which is later in childhood. We'll know the symptomatology and how to approach. We have got two eminent speakers with us, Dr. Shalmy and Dr. Leenatha, and one more moderator with me, Dr. Deepa. I would hand over to Deepa to start the proceedings. Thank you.
Good evening, one and all. We welcome you all to this second edition of Patient Awareness Program on under the behalf of ISPAE ACES. And this time, the topic is on hypothyroid, awareness program on hypothyroidism. I'm Dr. Deepa. I'm a pediatric endocrinologist and associate professor of pediatrics from Government Medical College, Thrissur. This program, ACES program, is a flagship program initiated by our ISPAE president, Dr. Shaila Madam. Can you please project Madam's slide? So Madam is a pediatric and adolescent diabetologist and endocrinologist. She's working at Shivajyoti Clinic and Manipal Hospitals, Bangalore. She's visiting professor of Bapuji Child Health Institute, Davangere, and she's author of various endocrine and pediatric textbooks. So for today's program, we have two eminent pediatric endocrinologists across the country. Dr. Shalmy Mehta from Ahmedabad. Next slide. So Hari is my co-moderator. He's a consultant pediatric endocrinologist from Nagpur. Next slide. Yeah, next slide, please. Dr. Leenatha is a senior consultant in pediatric endocrinologist, and she's one of our experts today. She's working at Rainbow Children's Hospital, Hyderabad. She has had her specialist training in pediatric and adolescent endocrinology and diabetes from Nottingham Children's Hospital, UK. And she's one of the founder members of Thalassemia Support Foundation. And she's co-organizer of pediatric diabetes for postgraduates. And she's executive member of Association of Clinical Endocrinologists. Welcome, ma'am, to this program. Our second expert for this session is Dr. Shalmy Mehta. She's a practicing consultant in pediatric endocrinology in Ahmedabad. She has had her training in pediatric endocrinology at Hospital for Sick Children, Toronto, Canada. She's the convener for Growth Chart training from Gujarat. She has authored several chapters and a textbook of pediatric endocrinology by IAP. She's a speaker at various state and national conferences and a mentor of diabetes education training ideal program. And her key interests include type 1 diabetes, precocious puberty, calcium, and bone disorders. Welcome, ma'am, to this session.
Thank you so much, Dr. Deepa.
Divya is also a part of our team. So she's a pediatric endocrinologist from SRMC, Chennai. So we'll directly go to our session. I welcome all the parents and parents who have joined this program. This session is on thyroid disorders in children and adolescents in children. So my first question is to Dr. Shalmy. Thyroid problems are seen increasingly in children. It is also seen in newborn babies. Can you enlighten the audience about what is hypothyroidism and congenital hypothyroidism, and what are the probable causes for congenital hypothyroidism?
Yes. Thank you so much, Dr. Deepa. I think it's a very relevant question, and we are seeing so many patients, who come to us with abnormal reports. So first, let us take a minute to see what exactly is a thyroid gland, right? So it's a small butterfly-shaped gland situated right here in the neck, but it produces a very, very important hormone, that is your thyroid hormone, which practically affects every system in the body, right from your heart, your digestion, your hair, your skin, your mental development, and your developmental milestones. So it is very, very important hormone. It affects every system in the body. Now, when we say hypothyroidism, so hypo means working less, right? So whenever your thyroid gland is not working efficiently, it is not making enough hormones, or it is making no hormones. That is called hypothyroidism, right? And what is congenital? Something which is present since birth, that is congenital. So if a baby is born with hypothyroidism, that is called congenital hypothyroidism. Now, the main hormones produced by the gland are T4 and T3. So if any situation arises where you do not have enough T4 and T3, that would be hypothyroidism. If we talk about the newborn babies, as to what is the cause of them developing hypothyroidism, so sometimes the babies can have no gland, right? They're born with an absent gland, or they have a very small gland, which is not making enough hormones for the whole body. Or say the gland is not located in the neck, but it is, somewhere else, it is misplaced. And therefore it is not making enough hormones. Or there could be a problem in the hormone formation. So there are multiple steps involved in the hormone formation. If any step is taken out, the hormone is not going to form, right? So there are multiple causes of why a baby could present with congenital hypothyroidism. I hope this answers the question.
Yes, ma'am, absolutely.
Yeah, thank you, Shalmy, for that answer. And okay, so Dr. Linatha, let us talk about congenital hypothyroidism first. And what are the symptoms which you find in a baby of a congenital hypothyroidism? Can you just give a brief idea?
Good evening, everyone. So as Dr. Shalmy has already mentioned, congenital hypothyroidism is something that presents at the newborn period or in the very first few months of life. And especially when these babies present to us in the newborn period, the signs might be very subtle, or they might have no signs at all. And that is because they have the protective mechanism which the maternal hormone provides to these babies. So the first few weeks, you will not actually pick up based on clinical symptoms. And later on, if there is a delay in the diagnosis of the condition, then these children might present with features of coarse facial features. They might have poor growth, poor feeding. Their muscle tone will be reduced, so they appear like a rag doll to us. They might have an umbilical hernia, that is just swelling at the umbilical area, distended abdomen, constipation. But some subtle symptoms that you can pick up early, some of these babies can be large for gestational age. If they present with jaundice, which is prolonged for more than 2 weeks, these are things that might sort of ring a bell to the pediatrician. So that is one of the biggest reasons, because we miss this condition in the newborn period. We are so focused on trying to identify it within the first 1 to 2 weeks of life by either doing a newborn screening or getting a thyroid profile done.
Oh, so true, Dr. Linatha. So coming to Dr. Shalmy, why it is important to identify newborns with congenital hypothyroidism? What can happen? What can go wrong with them if we are not able to identify on time?
Now, see, thyroid hormones are very, very important for the brain development. And that happens maximally in the first 3 years of life. So as Dr. Linatha said, the kids may present with probably very subtle symptoms or absolutely no symptoms because they have received thyroxine during the pregnancy. They have received the mother's thyroxine, right? So when they are born, they may not have any symptoms. So it is very likely that if we rely on the symptoms, we are going to miss these patients. So if we miss these patients, it is very, very likely that they may end up with poor IQ, poor mental development, and even severe mental retardation and delayed milestones, right? So because these symptoms could appear very, very late, when you are misdiagnosing these patients, it is very, very important that we pick them up very early before the symptoms arise. And we don't want the child suffering, we don't want the child having mental retardation and stuff. So it has to be diagnosed before 2 weeks of life.
Thank you, Shalmy, for that answer. And Deepa, would you like to ask anything to Dr. Shalmy?
Dr. Linatha, ma'am, you have told that the clinical features of congenital hypothyroidism are very subtle at birth. So how do we identify such children early?
See, the only way to identify it is by actually testing the blood for your thyroid hormone levels. And the best way forward is doing a screening. Now, screening is not universally available in our country. Most hospitals are trying to implement it in different ways. So one of the easiest a lot of hospitals would do is a cord TSH, which is done from the cord blood, which can identify children who are at risk of developing congenital hypothyroidism. Disadvantage of doing a cord blood is you can miss out the other conditions which might be picked up by doing a newborn screening. A newborn screening is using heel prick blood on filter paper, which can pick up not just congenital hypothyroidism, but various other disorders which can present and be diagnosed at the newborn period. Now, this should be done after at least 72 hours. In most Western countries, I think they do it on day 5, but in our country, because it's very difficult for us to access families once they leave, we prefer to do it after 72 hours. The other way, in case the hospital or the setup doesn't have a newborn screening or don't do cord blood, the other way to do is to do a thyroid profile, at least by the first week of life, just to find out what the levels are and then take it forward from them.
Thank you. Thank you, Dr. Linatha. So we have now understood that there is something known as a newborn screening, which helps to identify these children early. My question to Dr. Shalmy is that is newborn screening, is it a safe procedure or is it expensive? And
right. So as Dr. Linatha said, either we can do it from the cord blood, right? So that is, you don't have to prick the baby, you have got enough blood sample taken, and that can be done at the gynecologist itself. So again, no pricking to the baby, so it's very, very safe. Or if you're doing a thyroid profile, you're testing the blood of the baby by doing a venous puncture. Again, it's a simple blood test. So I would say it is not at all, there is no harm done to the baby at all. It's very, very safe. If you look at the expense, like if I talk about Ahmedabad, it just cost me 300 rupees to get a T4 and TSH done. So I think it's very, very inexpensive, but it is going to give us a lot of information, right? So therefore, we would say that a thyroid profile or a screening should be provided to all the babies. So there are no rules or no policies right now that suggest that, okay, every child has to be universally screened, though we would like to have that done. But, that involves a lot of government policies and stuff. But we as doctors and, our aware parents should ask our gynecologist friend also to start creating that awareness among the parents, like this is some test which might be needed to be done either from the cord blood or after your baby is born, and this is a must. So they are going to spend 9 months with the family, right? So their family puts a lot of trust in them. So it is very important that that kind of awareness starts from the obstetricians themselves. And then we have to create awareness among the pediatricians also. We would be very, very happy and grateful if every child is screened for hypothyroidism, but at least we can try our best.
Thank you, Dr. Shalmy. So this makes clear that a newborn screening is a very important procedure which has to be done in all the newborns born. But I just want to ask Dr. Linata that if a newborn has missed or a newborn has been missed by screening or not undergone a newborn screening, what do you suggest to all the parents who are listening to this video?
So if you've missed the newborn screening or the hospital where your baby's been delivered doesn't do a newborn screening or doesn't do cord blood, its best thing is to go and meet your pediatrician, because the pediatrician will be able to organize just a thyroid profile, which will include a T3, T4, and a TSH, which can be done in the lab. And that will give us a picture as to what the status of the gland is. Now, ideally, we want to try and get this blood test done well before 2 weeks, so that if there is any abnormality, then treatment can be started at the appropriate time. So it's just getting in touch with your doctor. It might be a pediatrician or your family doctor, and discussing with them, and they'll be able to organize it. And as Dr. Shalmy mentioned, it's a very simple test. It's just a blood test, small prick. Send it to the lab in the morning. You'll get the results by afternoon. So it's not going to take long either.
So yes, I come back to Shalmy for again the screening thing. How long does it take for a newborn screen to get the reports? Because the mother or parents are concerned that they won't be discharged waiting the reports. So how long it takes, and if it is positive, what should be done? What do you suggest to?
Yes. So if you're taking a venous blood sample, you get the results by 2 to 4 hours. So that quick you would get a result. So before the parent is discharged, they know what is happening with the child. Right? In case you get a positive screen, so there are certain cutoff values, that we would follow for the levels of TSH and T4 also. So if the screen is positive, your doctor is going to refer you to a pediatrician or a pediatric endocrinologist, where you might need to, kind of repeat a blood sample again, or do certain other tests, like, you want to do a sonography of the gland to see whether the gland is present or not. What is the cause of this abnormal screen? Right. So in case of a positive screen, you might be retested to confirm the diagnosis. There might be certain tests done to find out why this thing happened, and then appropriate treatment would be started. So I think it's a very, very simple disorder to manage, but very critical that the treatment be started on time. And as Dr. Linata said, within the first 2 weeks of life.
So suppose we have diagnosed a child with congenital hypothyroidism either by the cord blood sample or by the newborn screening. So how do we, when can we start the treatment in this children? And is it safe to start thyroxine tablet in a newborn? Dr. Lina.
Thyroxine is absolutely safe. There is no issue regarding taking that medication. Now, what is the right time to start depends on your TSH levels. Now, if your TSH level is significantly high, that is above 40, then that is a bit more of a concern. Now, if it is above 80, that's definitely a concern, and you would confirm it by a lab test and start them on medication immediately. Doesn't matter whether it's day 3, day 4, day 5, you're going to start it. Now, if you've got a level which is above 40 but below 80, then you might want to just repeat a lab test in a day or 2 just to see whether that's still elevated. Is it going up or is it settling down? Now, we do come across a lot of babies with TSHs which will be between 20 and 40, and you're not sure what is going to happen. Are they really going to need medication? In those babies, again, if they present you in the first week of life, you can wait for a week or a couple of days and repeat the test. Now, when you repeat it, you can just do a lab test so you can get information about the T4 or the free T4 as well. Now, if your TSH is significantly raised, even by the end of 2 weeks, then you would consider, you would want to start the infant on medication. Now, when you start them on medication, it does not definitely mean it's going to be for life, because there are some babies who might require it only as a transient hypothyroidism. But it is important to start treatment, because any delay is going to cause permanent damage to the developing brain. So if we think that this is a transient type of hypothyroidism, which will be based on lots of other investigations, then we can consider trial of medication after 3 years of age. But any doubt, your levels are significantly higher by the end of 2 weeks, it is advisable to start treatment.
So we have understood that thyroxine is a very important drug which should be started as early as possible, as soon as the diagnosis is made. And if you start the drug early, within the first 2 weeks of life, the child will become a normal child with normal individual ability.
Yeah.
My next question, Dr. Shalmy, is that what are the precautions that we should follow we should advise while starting a child or a baby on thyroxine tablet?
So I think the first is the reassurance to be given to the parents, right? That this is not a grave disorder. You don't need to worry about it. Your child is just not making the hormone and therefore you are replacing it from outside, right? Because often the parents are very worried, very anxious about what is going to happen to the future of the child. So it's very important that we do an appropriate counseling. We have already established what the cause of the hypothyroidism would be. So we can give an idea to them whether it's going to be permanent, or as Dr. Linata said, we are going to give a trial for 3 years and then see what happens, right? Now, thyroxine is available only as tablets. So we do not have any syrups, any drops for it. So it compulsory comes in tablets. Different doses and different strengths are easily available, right? Earlier, they used to come in glass bottles. So we used to advise the parents not to keep that in direct sunlight because it can, the potency can be affected. But you have to give the tablet once only in the morning. Now, because the baby is so small, we do not advise that you have an empty stomach because, the child may demand food anytime. So we just say that, okay, you maintain like a time slot in where, you're regularly giving the medicine, not forgetting it. You will crush the medicine and preferably give it with breast milk or say whatever formula milk the child is taking. And do not forget to give the medicine. That is very, very important. I think that is the only thing that we ask the patients to do is not forget the medicines. In case they have forgotten the medicine, then they may give a double dose the next day. But, we do not usually prefer giving double doses. So it's better just to remember that. But otherwise, this is a very, very simple disorder to manage. And the parents will realize that, once they're doing things correctly, they are seeing an absolutely normally developing child, so there is no difference between this child and any other child without hypothyroidism.
So congenital hypothyroidism is definitely a thing which should not be missed, and the child should be started on therapy with precautions. But how, Dr. Linata, how do we actually follow a case of congenital hypothyroidism? Once the treatment has started and diagnosis is done, what extra precautions we have to take and how we follow such kids? Can you just...
I mean, once you start treatment, again, that varies a little bit between a pediatrician or the endocrinologists. I tend to bring them back in 2 weeks just to make sure how things are going on and then recheck their levels and make sure that things are falling back into place. But the routine recommendation is that at least we follow them up once every 2 months for the first 6 months. One is to adjust the doses, see whether the child is growing well or not, also to get an idea of the development. And then once 6 to 9 months are done, then you can go on to 3 monthly. And then that can be continued till about 3rd year of life. And then if it's a transient picture, then you might consider a trial off. And if not, if it's going to be a permanent type of congenital hypothyroidism, you will continue medication and you will review them once every 3 to 6 monthly. And that continues till they've completed their growth. Because the dose increase tends to happen a lot in the 1st year of life and again during the pubertal phase where they have their growth spurt. So it's very important that we continue that monitoring till they've completed their growth. After that, again, 6 monthly is what we would recommend, especially for young girls, because you want to make sure that their cycles are regular, and later on during their pregnancy, would want them to get into the habit of monitoring it once every 6 months. The same thing applies to boys as well, 6 monthly to 12 monthly as adults. But until then, it is at least once every 3 to 6 months.
Thank you, Dr. Linata. And I will come back to Shalmy. And you suggested that you have to counsel the parents that it is not a grave disease, very grave problem, and counsel them that we are just replacing it. Still, many parents are skeptical and they are resistant to start because the child is apparently looking normal for obvious reasons. And they usually turn to you and ask this simple question: can my child have this thyroid problem can reverse as he grows, as a child grows, or is there an entity called transient variety of hypothyroidism? Can you just answer that?
Yes. So whenever we have a newborn which is diagnosed with hypothyroidism, we would usually perform certain investigations, right, to find out why the child has hypothyroidism. And the most common investigations would be to get a sonography of the gland and a thyroid scan. Now, the sonography will tell me what is the structure, what is the size, whether the gland is there where it should be or not. So say if the child is born with an absent gland, we know that the gland is not going to come after the child is born, right? So that is a case of permanent hypothyroidism. And these are the children who will need thyroxine for the rest of their lives. So they have to be counseled thoroughly that, look, the gland is not there. So we have to do the job of the gland from outside for the rest of their life. We also do a thyroid scan. So that will tell us the function, whether the gland is functioning properly or not. So now if both these investigations are normal, and because there were borderline thyroid issues and thyroxine had to be started, because you have to give the benefit of doubt. You cannot not start thyroxine because the brain development is at question here, right? So you have started thyroxine in these babies. What we do is we continue thyroxine till they are 3 years of age, because we need to ensure that the brain development is not affected at all. At 3 years of age, we would stop thyroxine for a month. If the thyroid report rises again or becomes abnormal, we know it is going towards a permanent hypothyroidism. Right? So now the gland itself is not working and we have to give the medicine from outside for the rest of the life. But if after not giving the medicine for a month, we feel that the reports are normal, that means the gland is working, it is making its own thyroxine, then we would just monitor the child, and probably that was a case of transient or a temporary hypothyroidism. But till 3 years, we'll have to give thyroxine. There is no question and no doubt about it.
So one more question attached to this. Shall we check only the kids or of mothers who have got hypothyroidism? And many times we hear that that the mother is hypothyroid, so please check, and whether the mother is the responsible for this congenital hypothyroidism, because parents, they usually ask this question. So
Yes.
can you just answer that?
And I think that is the most common reason why a baby gets tested, right? They should be tested, but because the mother had a thyroid disease, they will test the baby. So most of the patients that we have who have been diagnosed will have mothers who have got normal thyroids, right? It is possible that if a mother has got a pre-existing thyroid disease, she may pass on certain chemicals known as antibodies to the baby, which can cause temporary derangement in the baby's thyroid. It will usually be temporary and not permanent. But remember, it is not always the mother's maternal, like the maternal thyroid status, which is going to affect the baby. So irrespective of the mother's status, we have to check each and every child for hypothyroidism.
Okay, thank you, Dr. Shalmy. And I think Deepa has some question which usually parents ask about their kids. So please, Deepa, go ahead.
Most of the patients come to us and they are very worried about this diagnosis of congenital hypothyroidism. Many of them will ask them that is there a recurrence, chance of recurrence of congenital hypothyroidism in their next baby. So what is your advice, ma'am, Dr. Leenata?
See, basically, the most common causes for us to develop congenital hypothyroidism is either your gland hasn't been formed properly, or there is an enzyme defect which results in less hormone being produced. Now, the initial one is called thyroid dysgenesis, and most of the time it occurs just randomly. There is no inheritance, though there are few studies which show that there are familial cases, probably up to 2% of them. But what we do know is those who present with thyroid dysgenesis, where the gland isn't formed properly, there is a risk of other congenital abnormalities. So that is more important to screen for those than being worried about whether the next child will have it or not, because it's so sporadic. The other thing is also is that because we are so keen that we screen all babies, the next baby of this child or the sibling is going to get screened and going to be identified as early as possible. Now, thyroid dysharmonogenesis, where the hormone is actually produced insufficiently or completely absent because of the enzyme deficiency, these can be sometimes inherited. Now, it is an autosomal recessive if they are inherited most of the time. There again, 10 to 15% is there. That means there is a 25% risk that the sibling might have it. But from our own experience, I don't think we actually see many babies where the siblings also have it. It's a very rare occurrence. And even if we knew about it antenatally, we know these babies will do well if we identify it early. I think there is nothing we need to do, even if there is a high risk, because we know once they're born, you start them on medication, they're absolutely normal children. Some babies, if on ultrasound scan in utero, there is a goiter, there's this neck swelling, which is due to an enlarged thyroid gland. And in those cases, sometimes the mothers are given extra thyroxine medication into the amniotic fluid, but that's a very, very rare thing. It's just that's something the gynecologist would guide the families anyway.
Thank you, ma'am, for that answer. So that is a very common question asked to us. So there's very less chance for recurrence than an next baby, especially for dysgenesis. But if it's a dyshormonogenesis, there may be slightly increased risk for developing in the next baby. And the more important thing, as ma'am suggested, was that we should look for the congenital anomalies like cardiac defects, hearing defects, and things like that. The child should have a proper follow-up and all. So that brings to the end of our discussion on congenital hypothyroidism. So the bottom line of this discussion is that congenital hypothyroidism is a preventable cause of mental retardation, and we should identify them early, especially in the newborn period, because they don't have usually any symptoms and signs. And newborn screening is very, very absolutely essential. And we should spread this awareness among our family members, our relatives, and our close friends, that all babies, because it is not sometimes it's not universally done in all hospitals in India. So especially government hospitals. So we have to spread this awareness and among the general public, and all babies should have this screening, so that we can bring down this preventable cause of mental retardation in our country.
Dr. Deepa, if I can just add one more thing. Many times we have seen, that parents would stop thyroxine after they feel that the child is doing better, right? So everything is fine. So there is no need for the medication. So they need to realize that the child has gotten better because of the medication, and they don't have to discontinue it. So I think, again, this becomes a very important part of counseling also from our side, that, something has been started. It does not have to be stopped before the doctor tells you to stop, right? So, and if the baby is diagnosed very early, the child will never become symptomatic. So we often question, why is the need for thyroxine? So again, that counseling comes into picture a lot.
Absolutely, madam. That is the doubt. We have to counsel them properly, that they have to take this medication. It's absolutely essential for their brain growth and all. And many times even we see pediatricians stopping the medications in between at the age of before the age of 2 years or even infancy. So that should be strongly discouraged. They say that it is not. So even doctors, we sometimes find that they stop the medications, and it's very important that we spread this message to our friends and relatives that the medicine has to be continued anyways till 3 years.
Sure.
So we'll go to our next session, that is hypothyroidism in older children. So my question is to Dr. Shalmy, how often do you see hypothyroidism in older children?
Yes. So I think, again, that is one of the most common hormonal disorders in children that we see in our routine clinical practice. And if I have some incidence data, it would be like 1 in 1,000 to 1 in 1,100 kids would present to us with hypothyroidism. It is definitely seen more common in the girls as compared to the boys. And definitely, if you have somebody in the family who has hypothyroidism, you are more likely to develop hypothyroidism. And we often see it around the peripubertal age, right? So a child being diagnosed with hypothyroidism, that age group is more common. But again, it can happen at any age. But as I said, it's a very, very commonly presented hormonal disorder.
Okay, thank you, Dr. Shalmy, for that answer. And as we know that the symptoms in older children differ from the symptoms in infancy. So can Dr. Leenatha, can you tell what are the symptoms these children can have?
Again, even in older children, if your hypothyroidism is presenting very gradually and very slowly, you might not again see the symptoms. They won't be very obvious to you. One of the biggest ones, especially when they are slow in their onset and gradual progression, is effect on their height. It happens so slowly that by the time parents realize, there is a significant impact on their height. So that is one of the biggest things. Any child who's on the shorter side should have a thyroid profile done to rule out hypothyroidism. But there are other features as well, like increase in their weight, not significant like obese, but they do tend to gain weight without much of an increase in their appetite. They can have dry skin, brittle hair, they have cold intolerance, they can have myxedematous skin, they can be lethargic. The school performance is not affected. They tend to they continue to do well in school, but they have very limited energy. They come back, they just want to sleep. They just about manage to do their things. Puffiness also, facial puffiness is what we tend to see. Nowadays, I think parents are also quite aware, especially when there's a weight gain, they do tend to go ahead and do a thyroid profile. But though there is a wide list of symptoms, all the symptoms don't present in a single child. So we have to be very careful when we are looking out for symptoms, and careful in which child we screen and don't miss hypothyroidism.
Dr. Mehta for that answer. So my question goes to Dr. Shalmy, that what are the common causes? I mean, the causes of congenital hypothyroidism. Does the cause in older children differ for hypothyroidism?
Yes, so congenital, we said it's present since birth, right? So when we see an older child, if it was congenital, it would have presented much earlier. So the most common cause of hypothyroidism in the older kids would be Hashimoto's thyroiditis, like that is what we call in the medical terminology. It's simple an autoimmune condition where something goes wrong with the immunity and those antibodies start attacking your own thyroid gland. So it is called autoimmune. खुद का immunity खुद पे attack कर रहा है, right? So because of that, these antibodies, the gland is not able to produce any more thyroid hormones, and that is how a child gets diagnosed. So practically, you would say 90 to 95% of the patients would come with this diagnosis, that is autoimmune hypothyroidism. Now, there would be other rarer causes, like somebody has like a small gland. It was making thyroxine till now, but now it's not enough. So it's a form of congenital hypothyroidism, but presents very, very late. Or somebody has undergone some kind of surgical intervention or some radiation because of some other reason, and that has damaged the thyroid gland. Rarely now iodine deficiency, because now all of us are used to using iodized salt. So that is being rarely seen as a cause of hypothyroidism. But again, as I said, the autoimmune variety is the most common cause of hypothyroidism in older children.
Thank you.
So thank you, Dr. Shalmy, for that question. I would like to ask one more question to you. I mean, see, every time we get this diagnosis of hypothyroidism, whether in newborn or children, the parents, they are very, very hopeful that this is going to reverse. So what congenital, you explained very well, that it may reverse after and should be checked. But what about these kids or these children? Suppose a child is diagnosed at 5 years with autoimmune hypothyroidism and all the antibody and everything is positive, or a girl has been diagnosed with that. How long she should continue the therapy, and what are the chances of reversal, or what are the chances that the drug can be stopped in such kids?
Yes, so in case of autoimmune thyroiditis, in simple language, the antibodies have attacked the thyroid gland is not going to work any longer, right? So this is again a permanent form of hypothyroidism, wherein the child will have to take the medicine for the rest of the life. So again, that first visit and the first counseling is very, very important to explain to them that if the child takes the medicine properly, the child is going to grow and develop absolutely normal. There are not going to be any long-term issues with the child. I don't know, I get often this question that will the thyroxine affect my kidneys or not? I don't know, for some weird reason, they read in the newspapers and come with these weird questions. But if you replace the medicine in adequate doses, and that is why, as Dr. Linatha said, we monitor these patients very frequently to make sure that we are giving the correct amount of dose, not less, not more. So if you are giving the correct amount of dose, the child is going to do absolutely fine. It is more like a deficiency, right? The child is not making it, and therefore you're just replacing it. So if you do it correctly, the child is going to be absolutely fine. There's nothing to be worried about it. But yes, in all patients of autoimmune thyroiditis, where these antibodies are so strongly positive, you have to take the medicine for the rest of your life.
Thank you, Dr. Shalmy, for that answer. I think Deepa has to ask something.
Thank you, ma'am. So my next question to Dr. Linatha is that we have diagnosed, when we are diagnosed hypothyroidism in an older child, what are the tests that are being usually done for this children?
So the first thing you would do is check is for the antibodies, because autoimmune hypothyroidism is the most commonest one. And if you're antibody positive, as Dr. Shalmy said, the treatment is for life. On very rare occasions around puberty, some children might present with a goiter, that is the thyroid swelling, and their thyroid profile might be slightly abnormal, but they're antibody negative. And in those scenarios, though very, very rare, once growth is completed and if they're on a small dose, we might consider giving them, that group of children, a trial of medication. So yeah, doing antibodies is extremely important, because if they're positive, it means lifelong treatment. If there is a neck swelling, you probably do an ultrasound scan just to see whether, just to get the measurements and to make sure that you're not missing anything else. Because sometimes children present to us with neck swelling and the thyroid profile turns out to be normal. You want to know if there's anything else on the thyroid scan. There are other tests, more fancier tests, which will tell you about the structure of the gland or the functioning of the gland. These are routinely tests that we don't do. To find out the structure of the gland, sometimes we do that in the newborn period if we are able to do it within the first few days of starting treatment. It doesn't change our treatment. These are all investigations which can cost money, so it's not a compulsory test for the families to be done. Getting your diagnosis right, getting your antibodies done and starting on treatment and taking it regularly is more important. Follow-up again is very important. Especially during the pubertal phase, because there's a rapid growth, a lot of changes because of the hormones, and you need to make sure your thyroid profile is normal.
Many pediatricians advise FNAC for this thyroid swelling. So what is your take on that one?
See, if you're on an ultrasound scan, if your gland is normal in appearance and you have an abnormal thyroid profile, which says that you're hypothyroidism, you don't need to do an FNAC at all. Even if you have a gland which is enlarged and you have a normal thyroid profile, if there's nothing abnormal on the scan, it is not something we would recommend unless there is a strong family history of cancer, thyroid cancer. Even in those scenarios, you might find some changes on the ultrasound scan, which will tell you, yes, please go ahead, you need to do a FNAC. A lot of the time you might pick up nodules on a scan, and that could be a colloid nodule. And again, colloid nodules, you don't need to do anything about it. To reassure the family, you can sort of redo the scan in a couple of months just for reassurance and probably repeat a thyroid profile. But FNACs I would recommend it being done if you find something abnormal within the thyroid gland, which is suspicious, and then you get the right person to do it. And just not an FNAC. If you're going to do it, do an ultrasound guided biopsy rather than FNAC. But that is something to discuss. And it's not something we do very commonly in children. Probably occasionally in teenagers, you might consider it based again on what the scan shows us.
Thank you, ma'am, for that answer. Next, I would like to ask Dr. Shalmy. How should you treat hypothyroidism in an older child, and what are the treatment options?
So just like the newborn babies, now no longer thyroxine is made in the body. So we are going to replace thyroxine from outside, right? We have thyroxine available as tablets in various strengths starting from 12.5 to 150. So depending upon the weight of the child, your pediatrician will usually start the medicine. Very, very important that this medicine be taken on empty stomach. So we did insist that for the newborn baby because we know that it's not possible. They are always hungry. But now the child is older, they are able to take the medicine on empty stomach. So we advise them to take the medicine as soon as they wake up in the morning, and then preferably at least 30 minutes, they are not taking any liquids or anything to eat, because this medicine is best absorbed on empty stomach. Again, compliance is very, very important. So you have to take your medicine daily. In case you forget to take a medicine, you have to take twice the dose, so double the dose the next day. But again, if you forget it for 3 days, don't take a triple dose, right? Just take a double dose. So again, that is also very, very important. Regular investigations to be done as and when suggested by the doctor, because again, we want to make sure that we are giving the medicine in the right doses. So there are going to be periods of growth, right? When the child goes through puberty, and a lot of dose adjustments might be needed during that time. So again, close monitoring is very, very important. But yes, as I said, it's a very, very simple disorder. You just take the medicine in the morning. There are no specific food restrictions. Yeah. Make sure you're not taking any other medication along with the thyroid medicine. So say you have got a cough, cold, you have to take your iron tablets or calcium tablets. Make sure you have at least 1.5 hours gap between your thyroid medicine and any other medicine. But as such, other than soy products, probably there are no other food restrictions that would be taken. So child can live an absolutely normal life. Just take one medicine in the morning and the child is good to go.
Thank you, ma'am. That was my next question. Many parents ask us, are there any food restrictions? Because they are so keen, because they have read about these things in magazines and newspapers, and also many do ask
Yes.
about the food restrictions while taking thyroxine.
Yes, so probably nothing, like, most of our kids are on routine dairy, so they are allowed to take each and everything. They would say, can we give cabbage? Can we give cauliflower? Can we give, leafy vegetables? But everything is allowed, so there are no specific food restrictions, right?
Thank you.
So thank you, Shalmy, for that answer. And what I understood from the discussion is hypothyroidism can happen at any age in childhood also. And the most important symptom they present is metabolic issues like constipation and low energy, cold intolerance, and some kids with passage of time will present with short stature. And few of them will also have goiter or swelling in the neck. And the other thing we understood that the treatment, if the antibodies are positive, the treatment has to be continued for a long time, perhaps for the life. So, and we heard about the treatment options that we are giving a replacement therapy. Now, my question to Dr. Leenata is, you have already, Dr. Shalmy has mentioned what are the precautions are to be followed when thyroxine is taken. But what about alternate medicine? Because many Ayurveda or homeopathic practitioners, they actually claim that they have cured thyroid disorder, they have cured juvenile hypothyroidism, and once you start medicine, then it is going to be permanent. So don't start, come to us and we'll do the needful. And it is a very attractive thing for all the parents that once a doctor is saying, or a pediatrician or endocrinologist is saying that you need the therapy for entire life. So please don't stop and please continue. And someone is giving them a very lucrative kind of an option that, okay, come to me, I'll try to stop it. So how do we tackle such an issue, or what message you are going to leave with the parents?
Okay. Yes, we come across this very often. And what I've also from experience and all, when you talk to families and they actually, when they meet the right homeopathy doctor, experienced well one, they actually, the information they get is that you can't stop medication. What they claim is that if you give our medication, then the dose of the thyronorm or levothyroxine will come down. Yes, there is a lot of advertisements saying that we can cure it and all of that. When parents come to us and ask that, I usually say, see, again, I don't have much evidence on homeopathy or Ayurvedic to say that it's wrong. What I tell them is this is what is the right way forward. But if you want to consider homeopathy, it's your choice, but please don't stop the medication that you're on. If homeopathy and Ayurvedic medication does work, it's going to reflect on the blood tests for us, and we can always reduce your dose. When we tell them outright, yeah, don't do it, families will still tend to go ahead and do it. So it's rather you tell them that, okay, fine, if you want, consider trying it, but don't stop what you're doing right now. And then most of the parents will take levothyroxine. They also take homeopathy, and they realize that they're just taking too many medications, and they eventually come back to us and said, ma'am, we've stopped homeopathy because it's not made any difference. So this is what I tend to tell most of my patients, is that please don't stop your thyroid medication. If you're really keen on trying alternative, go to a good person, find out, do your research, and take a responsible action or responsible decision about it.
True.
Thank you, madam, for that moderate answer. And but important is I have seen, or we all must have seen people claiming, and the worst people to get affected is congenital hypothyroidism. I had seen 2 to 3 babies who have, like, once I told them that this is thyroid agenesis and we have to give therapy for entire life, then it is the other part of the medicine where they have chosen to go with some alternate therapy, and when they came at 2 or 3 years, they were completely mentally retarded. So it is a very dangerous thing to actually not to start therapy or not to continue therapy. So what you gave answer you gave, Dr. Lina, I completely agree with you that if that alternate medicine is working, then we can actually come down on doses gradually. We should not stop the doses. That should be the important take-home message.
But I
And
had like once a patient, they were put on some kind of homeopathy medicine, and I had to reduce the doses. It were very tiny doses. TSHs were very, very low. So I asked somebody else to check what was being given in the medicine. It was actually a thyroid extract, right? So then I explained to the patient, look, you are getting thyroxine anyhow. It is better we give in the recommended doses. We know actually how much we are giving. So we know we are not overdoing it. We are not underdoing it. We are giving just the right amount. Right. So that is also like so these things do happen and we have to try our best.
Another problem during this COVID time is that they lost follow-up for around 2 or 3 years. So they think we are not consulting doctors. So why to take medicine? That is that's what they think. And many children with congenital hypothyroidism, we have seen that they have stopped the medications and come to us. So
yes,
it's important that we counsel them properly initially. That the compliance is very important.
it's true.
so thank you, Dr. Lina and Dr. Shalmy, for the wonderful discussion on hypothyroidism in both congenital and juvenile hypothyroidism. I would like to invite Dr. Divya Lakshmi for the vote of thanks. Thank you.
Thank you so much for having us here.
Yes, thank you.
Shaila ma'am,
yeah, I was also like asking Shaila ma'am about finishing comments.
No, the discussion went on very well. I think most common things and very nicely explained and discussed. My net is very poor, so I'm not switching on the video still, not reached yet. Yeah, good. Thank you very much, Shalmy and Linata.
Thank you
Thank you.
so much, ma'am. Thank you.
So, I mean, this is the 20th series of academics and clinical education a program conducted by Indian Society for Pediatric and Adolescent Endocrinology. So, ACES Meet is the brainchild of our president, Dr. Shaila Bhattacharya ma'am. And I'm very much indebted to her because she had, allotted this program under my care, and we have been doing it well so far. There are like 2 Q&As, like would the speakers would like to answer, or
Yes. So the first question is probably how many children are diagnosed with congenital hypothyroidism? Again, especially the data that we have from India is as frequently as 1 in 1100 to 1 in 1200. So I think 1 in 1700 is something that is projected, but very, very frequent considering the number of babies that are born every day in India. So quite frequent.
I think the second one is, what's the probable cause for autoimmune hypothyroidism in older children, commonly asked by parents? See, the autoimmune, the word itself is saying that it's your immune system. And we've sort of seen a huge surge in immune related disorders, not just in children, but even in adults as well. So basically what it means is your immune system has reacted to something. It could have been a virus, it could be something allergic or something, that your immune system created antibodies, which in these antibodies sometimes look at their own system or their own parts as a foreign object or a foreign being, and they start attacking it or prevent it from doing its work. And that is what is called as autoimmune. So autoimmune hypothyroidism is your own immune system, the child's immune system, which is preventing the gland from working. And as of now, once antibodies are being produced, we are unable to stop it. So unless something in that works out for us scientifically, something comes up, treatment has to be continued. So that's how autoimmune hypothyroidism occurs.
excellent. So thank you, Dr. Shalmy ma'am and Dr. Lenita ma'am for very excellent and lucid talk on our patient awareness program on hypothyroidism in children. And I thank Hari and Deepa for helping me out in this meeting in the organization of it. So the next month program will be on the last Saturday of October. And we will be conducting this for the doctors, mostly as usual, how we conduct an educational program for our fellows and postgraduates. So thank you all. Thank you very much for joining us in the program. Have a good day.
Thank you. Thank you so much. Good night.
Thank you. Bye. Good night.
Thank you.
Good night.
Bye bye. Good night.